Hi, and welcome to Essentials of Acquired Brain Injury. Today we're going to be talking about cerebrovascular disease, strokes, transient ischemic attacks, things like arteriovenous malformations, and other blood vessel disorders that can lead to acquired brain injury. We're going to be looking at the causes and some of the long-term effects and the treatments. I do want you to know, and I want to bring this up right away, this is meant for education. This is not a replacement for a doctor or going to the ED. If you think you have any of the symptoms of a stroke, a TIA, any kind of vascular or brain injury, any kind of those problems, seek help right away. Call 911, go to the emergency department, contact your physician right away. Okay? So, first of all, let's talk about some of the statistics. The average person has a 1 in 6 chance of experiencing a stroke in their lifetime. Now, obviously, we associate this with older folks, people above the age of 65, senior citizens, that kind of thing, grandma's stroke, that kind of thing. However, you have a 40% chance of experiencing some kind of vascular incident at some point in your lifetime when you are below the age of 65. And we've been seeing rising numbers of people in their 20s and 30s having some kind of rupture of an artery. Not the ischemic types, but aneurysms and hemorrhagic type strokes, bleeding, and we will get to that in a moment. However, it is important to keep in mind that anyone can have this happen to them. So if you think you are having a stroke, it is critical, or you think a loved one is having a stroke, you must call 911, or you need to get them to the emergency department right away. It's not something to delay, wait, see if it gets better. Strokes are one of the leading causes of death in the United States. So it is critical, absolutely critical, to get help right away. And there are things that can be done if you act quickly. It's why we use the little saying FAST for strokes. If there's a facial droop, if one side or the other of the face, if the lip droops, or if eyelid droops, eyebrow droops, if they are having trouble talking, if they are having trouble with their vision, if they're having trouble with their speech, if they can't say, like, the sky is blue in, whatever state you're in, or, they can't say their name, if they're mumbling or slurring, call 911. If they're dizzy, if they're having problems with their coordination too, if they're describing the worst headache of their life, if it's a sudden and severe headache, a thunderclap headache, as it's often called, that's often a sign of bleeding in their brain. Sudden loss of consciousness. Any of these things. Here's a poster from the American Stroke Association. These are a key sign that they're having a stroke. So, any of these signs, please, 911 right away, emergency department immediately, and there we will get to the treatments and things that can be done. All right. So what exactly are we talking about? What is a stroke? What is a transient ischemic attack? What are all these letters and things mean like that? Well, all right, there are two primary causes, or things that interfere with the circulation to the brain. You can have either what is referred to as an ischemic stroke or hemorrhagic stroke. And basically what it is either blood supply is cut off, and that is in the case of an ischemic stroke, or you have a blood vessel will burst, or several blood vessels will burst, and you will have leaking of blood into the brain in different areas. So basically, an ischemic stroke is where you can get a couple different reasons for this cutoff of blood supply. You get large artery atherosclerosis. And basically what this is the traditional image. This is where a bigger artery that's feeding the brain, one of the lobes, or that is feeding the deeper areas of the brain, over time you get what's called a thrombus, which is an accumulation of plaque, fats, and other things that you may have eaten or whatever, and it slowly closes off that blood vessel. And eventually, when enough food and nutrition is cut off, it can kill off that a certain area of the brain. We'll get into that in a little bit. You also can have a lacunar, or a small area, a small blood vessel gets closed off by a similar mechanism, but it's just a smaller area of brain. And you can get some different symptoms, some much more specific symptoms from these, because it hits a very small area instead of like maybe taking out speech or vision or causing double vision or whatever. This may cause just behavioral changes or changes in speed of thinking or things like that. So lacunar type. You also can have a cardiac embolism, which is basically where it's a piece of a clot that breaks off. If you know, this is why they warn you about not sitting too long in an airplane or whatever. A piece of a clot from your leg or from an old wound or whatever, it may break off and travel through your circulation and be pumped up into your brain and block off a section of artery. And what's important is these things you find in your arteries, because it's your arteries that are under pressure. And so your veins tend to drain away, but your arteries deliver blood to your brain and nutrients. And we've talked about this before. So an embolus will travel through your body and lodge. Now you can have emboli of other things too. You can have an amniotic fluid embolus. Obviously that's pregnant women who get these, but if some amniotic fluid were to get into your circulation, and that does happen in some cases, it can travel around your circulation, forms a bubble, and would travel around and lodge itself in your brain and can affect, your brain as would a, clot-based one. It can kill off tissue in your brain. It can have effects your personality and or your thinking and vision and other things. So, but that would be based on anything that can plug up an artery would be considered an embolus. Emboli move. A thrombus forms in its own location, forms where it is. So you can even get an air embolus, an air bubble that will travel. It takes a lot of air to do that, but it can still happen. There have been weird cases where, like using an air gun or something like that, somebody accidentally, or plastic. When starting IVs or things like that, where there have been these incredibly rare, unusual accidents, can happen. So, but they often refer to these as cryptogenic emboli. You also can get a growth, a fungal growth or something like that, that can develop inside blood vessels. Again, these kind of things are really rare. This is not something, this is rare enough to like make the medical literature. So this is not something you should be, oh my God, all the time, or no. This is stuff that makes journal articles, like unique case studies. So this is not a common kind of thing, but it can happen. You also can have like problems with coagulation. If you were born missing certain genetic factors that help you code for how to put this, how you break down clots in your body depends on certain factors in order to dissolve clots. And if you are missing those certain factors, you might form big or small clots, which can form in your brain and cause cutting off of oxygen to certain areas. And so just like when I talked about hypoxic and ischemic damage, this is the same thing. However, this is due to genetic problems, and it just so happens that a clot like this may form in your brain. You may also have damage to your blood vessels. They may be malformed, and so they may be stickier than they should be, or a piece may break off and block flow. Vasoconstriction. People with migraines and other cerebrovascular disorders may have blood vessels that clamp up. And during surgery, sometimes this response can be triggered, or medications that may cause vascular constriction in the brain can cause the blood vessel tightens up too much, and it does not relax like it should. It doesn't get the right signaling to relax, and you can end up with a stroke, a lack of oxygen to certain areas of your brain, throughout your brain, and that may cause anoxic brain damage, which is really what this is all about. So there are a lot of different things that have the potential to cause an ischemic stroke. An ischemia, just like a heart attack, it is a brain attack. It is lack of oxygen, and it kills off areas in your brain potentially due to a lack of oxygen, whether it is plugged up or whether it is constricted due to vasoconstriction. You can see this in surgery. Again, sometimes it's rare, but can happen. All right, then there are hemorrhagic strokes. These are ruptures of arteries. You can also get small bleeds from capillaries as well, but that's less imminently threatening, and they often are self-repairing. But an artery is under pressure, and so if you get a tear, that can be obviously quite catastrophic. One of the things that's common is in a motor vehicle accident, you can tear your arteries, and we'll be talking about circulatory system in a moment here. We'll try to make it in digestible chunks. But if you tear in a car crash your internal carotids or your vertebral arteries, you can suffer an extreme brain bleed, and obviously that kind of damage can cause massive damage. Your frontal, your temporal, parietal, occipital lobe. It could do damage to midbrain structures. It could even leave you in a coma for long periods of time. It has to be repaired with neurosurgery. You also can have arteriovenous malformations, which is you're born with this problem. This is not something that you suddenly develop, but where arteries and veins will make a connection to form capillary beds and other structures, they sometimes misform. And due to genetic instructions, it's a congenital problem, but it's like a ticking time bomb. Here's an image of an AVM. And sometimes, if you're under stress or just, they can leak or they can rupture, and you get massive bleeding in the brain. Remember that hemorrhagic events, hemorrhagic strokes, represent 15% of brain injuries. 85% are due to blockages or vasoconstriction. But you have the double problem of not only lacking oxygen and circulation, you also then have the problem, we've talked about this in traumatic brain injury, edema and swelling, and then you also get vasoconstriction. This is why these are so deadly, is because it's a two-hit. And so you also get the damage from that. This is a critical neurosurgical emergency. One of the key signs is that thunderclap headache, sudden onset of visual problems. Many times there's vomiting, there's the dizziness, there's the alterations in behavior, even immediate unconsciousness. This must be surgery immediately, neurosurgery. As you know, we said in emergency and trauma, we always said they need bright lights, cold steel. They need to be under a neurosurgeon's knife right away. There also are, some people have problems with how the blood vessels are put together. And so they may leak. They may have they're called berry aneurysms. It's almost like an aneurysm is almost like a blowout in a tire. like those of you who are old enough to know the weak walls of a tire, it's the same thing. You get delamination inside the vessel where the layers of the artery here separate. And over time, it starts to balloon out. Now, you can have these kind of aneurysms elsewhere, the abdomen. You can have spinal aneurysms in other places, and it requires something called magnetic resonance angiogram for visualization and tracking. And there are neurosurgical fixes for these, but it is important to keep on top. Physical trauma can do damage to blood vessels. Abuse and like repeated head injuries can weaken blood vessel walls and put you at higher risk for this kind of thing. Here's image of what this looks like. Part of the reason they do CT scans on head injury survivors is to look for this so that they can fix it, because many people with traumatic brain injury also have bleeding, and the bleeding is due to damage to arterial structures in the brain. So just some people have hemorrhagic disorders. So you get more of a leak. Remember what I had said in the past when talking about the blood-brain barrier. It's not a perfectly tight leakage is possible. And like the old idea of Chinese water torture, drip, drip, drip. If you have problems with coagulation and you're too coagulated, something small, like just a simple fall down a stair, or just a simple bump to your head, and you're taking anticoagulants, or you have a coagulation disorder like hemophilia, because you're missing certain clotting factors, that can lead to a hemorrhagic type stroke. Tumors can bleed. Brain tumors can bleed because they have aberrant circulation, and it leads to increased bleeding into the brain. So you not only have the effects of the tumor, you also have the risk caused by the tumor. So one has to keep that in mind also. As I had mentioned before, surgical and use of radiation, chemo, can also alter not only the blood vessels, but you also then would have damage to brain tissue as well. There are also silent strokes. Now, silent stroke is one that may not show symptoms when you are looking at the brain for, when you're going along, you may be like, something doesn't feel right, but I really am not sure what. You're not showing neuro symptoms. But if you scan the person, you will be able to actually see damage in the brain on scans. This is an image of a so-called silent stroke. Obviously, this is a problem because if you have one stroke, your chances of having another are 25% higher. So it's important to know that you've already had one. And those of us with brain injury are definitely at a higher or 3 times higher risk if we have TBI or other brain injuries. Also, infections increase your chances. So if you have meningitis, encephalitis, sepsis, any of these that affect your brain, you're at a higher risk of strokes. Both kinds, both through edema as well as damage to the vasculature of the brain. Brain injury, the gift that keeps on giving. And if you have strokes, it affects your balance and increases your chances of having a head injury. And the medications that we use to treat increase your risks of bleeding. So we have to watch to make sure you don't have rebleeds. All right, so we talked quickly about ischemic, which are anoxic, hypoxemic types, and hemorrhagic types of strokes, versus, say, transient ischemic attacks. These are a warning sign. A transient ischemic attack is a brief transient neurological sign or symptom caused by usually either vasoconstriction, blood vessel shuts, constricts, or a temporary blockage. It's usually painless, and it may be like double vision, trouble talking, dizziness. It feels like a stroke, but it's not. And so it's just, it is less than 24 hours. It is an kind of sign because it is reversed, but it tells you need to act quickly. You need to make some changes. You may need to have a procedure. And just like fast, you need to go to the emergency department. You need to talk to a neuro, maybe have a neurosurgeon, and fix what the problem is, because the next time you have something, it may actually be a full-on stroke, and the damage may not be reversible. So if you have a transient sign, you need to seek help and treat it like it is a full-on stroke, because that may be the only warning you get. And again, it's problems with your speech, problems with coordination, movement, drooping, facial droop, double vision, strong, sudden headache, problems with coordination. So right away, always. Let's talk about the circulation. Your brain, the cerebrum, is fed by two sets of major arteries. And so they are the vertebral arteries, which feed the posterior aspect of your brain, and the internal carotids right up here. Those two sets bring blood up, and the vertebral arteries back here merge together and with these guys here, and they form what's called the circle of Willis. They first form the brachial artery, and then the basilar artery. Little buzzer there, tongue tie. The basilar artery, and then they form what's called the circle of Willis. Here's a map of what that looks like. The reason this is important is because based on symptoms that a patient has, you could tell what is wrong. The anterior circulation to the brain for the frontal lobes and temporal lobes is fed by the anterior communicating arteries and the anterior cerebral artery. Okay, and so that we all know symptoms for frontal lobe damage, and then the middle cerebral artery, posterior cerebral arteries, they feed the occipital lobe, which we have talked a little bit about. That is especially the central aspect, and posterior parietal lobe, and those deal with vision as well as portions of the temporal lobe, which affects memory. And based on certain assessments, you can, which is not so visible with neuroimaging as much as it is through neuropsychological testing. But if a person has a lot of memory deficits, you could tell that it's vertebral and it's the middle cerebral artery or the posterior cerebral artery that's been affected. If they have behavioral deficits, then it's more likely it's the anterior communicating artery. If they get mad, if they're easily irritable, or if they're kind of adynamic, confused, if they have executive deficits, that's between the anterior cerebral artery, and some middle cerebral artery. It's important to understand that there will be areas of focal deficit, and then you have what's described as the penumbra. So the area where you have the actual bleed will have significant tissue loss, and you'll have symptoms from that area. But you also will have some decreased circulation and some symptoms from damage generally around there. So if you lose speech function, you may also then have damage to dorsolateral area, because that area in the frontal lobe is a little further back, but you may also experience changes in planning and organizing, as well as trouble talking. You may have like Broca's aphasia, where you may understand more than you can actually say. But if you have problems with posterior middle cerebral artery, if that's what was damaged in an ischemic stroke, you may have trouble more understanding, and you may just say words without actually being able to put them together. And so you may have trouble with reading, writing, and other associated functions because of penumbral damage. So it's important to keep that in mind also. So what you expect depends obviously on which areas have had circulation affected, and if it's a major bleed, or if it is a large artery that has become obstructed, you can expect significant damage throughout an entire lobe or maybe multiple lobes. Or if it's bleeding deeper into the brain, this may affect widespread areas. They may have some behavioral issues, but they may also have some visual areas. And so if it's a stroke in the thalamus, which is responsible for distributing information throughout the cortex, it's like, and so you can use this information based on a neuropsychological assessment to determine location if you're having trouble seeing, based on imaging, where the deficits are coming from. So this is why doing certain type of testing, like neuropsychological testing, is important. Also, different types of imaging are helpful. Most of the time you'll initially get a CT scan. When you end up in the emergency department, they will look for, are you having a hemorrhagic type stroke? Are you bleeding? Do we need a cut right away? And if so, there are a variety of different repairs available. First, they have to drain the blood. Second, they've got to find what's bleeding. They have the ability to either laser and seal it. They may clamp it off. Surgical clamps used to pin it off. They may coil it. If you have a ballooning aneurysm, they have the option of using a surgical coil. In some cases, they use, in my nuclear medicine episode, I talk about the use of radiation to burn it shut. They use electroablation, or they can use stents. They can go in there and stent off. They also use stenting for ischemic strokes. They can use a laser to blast, basically open a blocked artery. A stent is kind of like a very compressed coiled piece of metal with a coating of a drug that will dissolve the clot and then expand to keep that artery open. They use that for either thrombi or an embolus, and it will keep it expanded and open. It's kind of exactly the same, kind of, as what they do for a heart attack, for an ischemic attack. So
This is the right MCA through the aneurysm, stent-assisted coil embolization. using an unusual access through the posterior communicating artery. The reason for this unusual access was this patient is a 64-year-old male with a significant medical history with bilateral carotid artery compromise, the right side being occluded, and patient had a previous ECIC bypass with a saphenous graft that thrombosed. The anterior communicating artery is quite small, as you can appreciate, and the only access to the intracranial circulation for this patient was using the posterior circulation. The patient started to develop headaches, and on workup showed to have a newly diagnosed right MC aneurysm that could be related even to the suture line of the previous bypass. The as you can see, the angiogram, multiple views reveal that PCOM was a better access than the anterior communicating artery. So we decided to proceed with a stenting coil treatment of this right MC wide neck aneurysm using an SL10 and a synchro wire and navigating through the posterior circulation into the posterior communicating artery retrograde and getting access to the M1 in this position is somewhat tricky. The catheterization of the PCOM is something that was likely easily done because of the occlusion of the right ICA, so making the PCOM more dominant. But you can see here on the navigation that there's a little bit of an angle that needs to be straightened using the synchro wire to be able to navigate the microcatheter. But having a distal position of the wire is very important. And as you can appreciate, one cannot visualize very well the anatomy of the middle cerebral artery as you're advancing the wire to give you more support. And so it's very important that once you're able to have enough wire purchase, safely navigate the wire, you can then make the microcatheter go around the band of the posterior communicating artery from the P1 position. But once you are into the anterior circulation, it's very important to repeat the roadmap and from the microcatheter so you can then see the anatomy very well. At this point, it becomes relatively straightforward in the case that you can navigate into the M2 and proceed to deploy, in this case was an Elvis Jr. Stent from the M2 to M1 to protect this wide neck aneurysm. Needless to say, this patient has been fully heparinized in ACT of 250 and is on dual antiplatelet. But you can see that this navigation now becomes relatively straightforward. One has an option to use an intermediate catheter, which could be provide more support. But in this case, we were able to make this relatively low profile with a 6-French guide catheter and an SL10 microcatheter to be able to get full access to this lesion. The choice of going endovascular, not open surgery, is not only the fact that the patient has had a previous craniotomy on that side and for the bypass, and also the fact that there may be a complexity from scar tissue or the previous saphenous graft suture line to the middle cerebral artery. The advantage of using this system is that you can use the same microcatheter to do the stent deployment, and you can see here the stent was fully deployed. Now you can advance the catheter into the stent using the delivery system or delivery wire. Confirmation angiogram is done through the microcatheter, and once the microcatheter is inside of the stent, you replace the synchro wire and get access to the aneurysm now going through the stent struts to start the coiling procedure. The advantage of using this type of construct is that now we have complete support at the neck of the aneurysm, so that the coil procedure can be somewhat undersized, so that we have an easier time not having catheter kickback and so forth. Here it's really important technical aspect, which is the wire has to have a good purchase inside of the aneurysm, and at the same time the microcatheter has to freely navigate. And you can see as it's advancing forward, there's a little bit of a jump that has to be controlled and carefully done. But if there's any resistance on the navigation of the microcatheter through these 10 struts, one has to reposition the wire and try a different path. Now the coiling is done relatively simply without any challenges, since you're providing somewhat of a you have a support from the Alves Jr. At the neck of the aneurysm, and the coil is about 1 millimeter undersized. Second coil is going in, trying to keep the microcatheter in position and avoiding being kicked out, so that the procedure can be efficient. And after the first coil is placed, we tend not to use a roadmap and just use fluoroscopy. As you can see, the runs are done basically through the microcatheter to confirm the occlusion of the aneurysm. And in this case, due to the presence of a stent and the coils, we have the aneurysm having still some residual filling, but with a very good reconstruction of that area. This is likely to thrombose since the main flow through the carotid artery is occluded, and this is all filling from the posterior communicating artery. We hope that this video was helpful to understand a option of using the posterior communicating artery as a retrograde access to coiling of anterior circulation aneurysms in the case of challenging anterior circulation anatomy. Thank you.
These are just some of the options available. They used to use cutters. They can inject directly into the area that has ischemia certain drug combinations. TPA, which is a drug that dissolves a clot, but they don't do that alone anymore. Most of the time, then they will put a stent in there to keep the blood vessel open, which has TPA on it to keep the blood vessel open. Physicians will frequently then, the doc will frequently check to make sure that you have good circulation in those areas afterward. These are the neurosurgical treatments that are typically applied for the two types of strokes, as well as monitoring afterward, helping keep blood pressure down, using blood pressure medication, helping to look out for cholesterol, statins to help keep the cholesterol down, change in lifestyle, better diet, because time is brain. And so really, as best as we can, try and improve lifestyle. Diabetes increases your risks of stroke. Both kinds, frankly. A lot of processed foods and things like that, also bad. Smoking is terrible and increases your risks. Trauma, head injuries, also increases your risk. Atrial fibrillation needs to be corrected, because that also can lead to stroke. Because if the atria are not beating properly, the quivering in there gives your blood cells a chance to clot and form a clot and travel to your brain. Sorry, struggling with a little word finding today. Just So it is important to have heart rhythms corrected. If you have a PFO, a patent foramen ovale, try saying that 5 times fast, you are at increased risks for stroke. You need to have that corrected. Even kids get strokes. And this is one of the leading causes to why kids may have a stroke. These are just some of the things. Oftentimes in a smaller hospital, they will give tissue plasminogen activator. There it is. I knew it was in there somewhere. TPA, a drug which mimics the natural substance used to open up or dissolve clots. There have been experiments with other medications. You may have seen these on TV where they mention using Gila monster venom or snake venom, stuff like that. We'll see where these all go. Again, cooling a patient using the cooling protocols for head injury. These offer potential for treatment. The symptoms are pretty much the same that you get for traumatic brain injury. And I've mentioned these as we've gone through: dysexecutive syndromes, personality changes, problems with thinking and processing speed, problems with memory, both long and short term. Aphasia is a big one. Broca's aphasia, where I mentioned that, defined by a neuropsychologist, an early neuropsychologist, Broca, and his patient who had a stroke in Broca's area, which is like on the left side in this area here in the frontal, which handles motor programming. So his patient would repeat over and over a single syllable in French, but did seem to understand. Wernicke's aphasia, which is a different type where you get word salad out of the patient because they can say the words, but they really don't have much understanding. That was a German neuropsychologist about a decade and a half later who did work on that. Wernicke, obviously. And so you get a lot of these specific or more specific kind of syndromes that you see with these types of strokes. Just again, another reminder about FAST.
When someone is having a stroke, every minute counts. Just as putting out a fire quickly can stop it from spreading, treating a stroke quickly can reduce damage to the brain. If you learn how to recognize the telltale signs of a stroke, you can act quickly and save a life, maybe even your own. For both men and women, look for these 5 signs of a stroke, all of which come on suddenly. 1. Numbness or weakness in the face, arm, or leg, especially when felt on just one side of the body. 2. Confusion, including trouble speaking or understanding speech. 3. Trouble seeing, from one or both eyes. 4. Trouble walking, or problems with balance or dizziness. 5. Headache, especially a severe one that comes on suddenly. The clock begins ticking as soon as you spot the signs of a stroke, because some treatments can only be used if the patient reaches the hospital in the first 3 hours after symptoms appear. So don't wait. Call 911 right away and get the person to a hospital immediately, even if the symptoms go away. If you think someone is having a stroke, remember the word FAST. F is for face. Ask the person to smile and check whether one side of their face is drooping. A is for arms. Have the person raise both arms and see if one arm drifts downwards. S is for speech. Ask the person to repeat a short phrase and notice if their words sound slurred. And finally, T is for time. If you spot any of these signs, call 911 right away to get the person to a hospital fast. Strokes are medical emergencies. The sooner a patient gets treatment, the better their chance of a good recovery.
And recognizing symptoms associated with cerebrovascular encephalopathy. Over time, one of the best ways to identify this, besides the symptoms and the risks, is that there's brain atrophy. It is a significant cause of disability in the United States and around the world. If you or loved one is showing any sudden signs, please take them to the emergency department or call 911. Get them in the hands of a neurosurgeon or a neurointerventional radiologist. They work in the neurocath labs, and they could do a lot. And if they act quickly enough, they could totally reverse the potential damage. And so that is a survey, a summary, and we will get more in depth in the future about specific conditions and syndromes associated with vascular disorders. But I wanted to give you the 10,000 foot, 20,000 foot view of what strokes, hemorrhagic and ischemic, what they are, what they do, and just so you can understand a little more about what's going on, about some of the options and ways to deal with. Rehab is pretty much the same as it is for brain injury: PT, OT, speech, language, cognitive work, therapy, psychotherapy, work with a brain injury medicine physician. And hope you found this helpful. Please leave comments. If you're watching this on YouTube, like, subscribe, share this with people who would find it helpful. And have a good day. Bye.